Welcome to the Putting the Public into Health podcast by Dr. Richard Pan. As we face one of the greatest public health disasters in a century, this podcast will address issues and questions from you, the public, about the COVID-19 pandemic and its impact on people's health and lives. I am Dr. Richard Pan. I'm a physician with a background in public health, and I am proud to represent the people of Sacramento, Elk Grove, West Sacramento, and parts of Sacramento County in the California State Senate. I want to share with you important information and stories to help each other during this difficult time. I have received many questions about testing for COVID-19, and many experts have said we need to do much more testing. On this podcast, we'll be talking about what is being done to increase COVID-19 testing. I am pleased to have Dr. Tran join me today. Dr. Tran is a director of clinical chemistry, special chemistry, toxicology, point-of-care testing, and specimen and reporting center, and associate clinical professor at UC Davis. He's a member of the governor's task force for COVID-19 testing. Thank you so much for joining me, Dr. Tran.
Thank you, Dr. Pan. It's a pleasure to be here.
So tell me about the governor's task force on COVID-19 testing. What is it supposed to do, and what's your role in it?
Yeah, no, that's a great question. And so pretty much the main goals out there is to, pretty much increase our capacity for testing, right? That's a big and well-known objective right there. But also really to bring in all these other tests out there to help us evaluate the epidemiological spread of this virus as one example, and of course give people more access to the COVID-19 tests that we've seen out there. So those are two key areas, and I know the actual governor and the state, of course, has partnered with UC Davis and UC San Diego to help set up several hubs, first of 5 hubs, to be able to push all this testing out there, in addition to all the many other places out there in the state that are doing testing.
Great. So one of the things that has been happening in California is that we've been very successful in flattening the curve, staying at home, so people are doing the things they need to do, and you could see the results in the rates of hospitalization that we're seeing in California in contrast with other parts of the country or even other countries in the world. So we've certainly been very successful. But one area where we haven't seemed to be as successful is actually in terms of the number of people we're testing or the percentage of people we're testing. So why has California been testing fewer people than many other states or countries?
There's challenges with that. One, we have a very large population, but really, this is the national problem of limited reagents, right? The testing reagents themselves are very severely limited in the early phases of this pandemic, but also there are many parts to the testing process that can be impacted by the supply chain problems. Early on, there were also extraction kits. For those that don't know, a lot of these tests that we use to be able to pick up the virus require us to use chemicals to break open the virus to release their genetic material for us to test. That was made by a completely different manufacturer, and they were a short supply. And now we're seeing challenges with swabs and media. So, the swabs that are put up someone's nose or in someone's mouth to be able to collect a sample, those are in short supply. Even though there could be millions and upon millions of these swabs in the nation, well, there's a lot of people doing testing. And for those that don't know, these swabs and media are used for non-COVID testing too. During the flu season, these were also equally used for flu testing. These were equally used for testing for other respiratory diseases as well. So all those things came into play when this pandemic occurred in the middle of a seasonal flu that then impacted the state as well as the nation.
And we actually had an early flu season, right? And although now with COVID, we're not thinking much about the flu, it was actually a somewhat severe one, wasn't it, in terms of people needing to run tests and identifying flu earlier on this year?
That's correct. At least from our perspective at UC Davis, knowing that it was a relatively worse flu season, by December, for the most part, and maybe early December, late November, given that we knew that China had the potential for a pandemic, we were actually starting to increase our supplies for flu testing kits as well as what we call a respiratory viral panel, where we can test for flu and several other viruses and bacteria that cause respiratory diseases. We knew that this was going to be used a lot more to help resolve what could be infecting the patient, but as we headed into January, of course, COVID really propped its head in the United States, and of course, state of California. Then, of course, that started a different response plan, meaning that we now had to bring in other tests, obviously for COVID-19, but then consuming the same supply chains.
So the governor has presented a plan for trying to get us, I guess I wouldn't say back to normal, but being able to lift some of the restrictions. And the first step of that plan talked about needing to be able to identify people with the virus and then contact tracing and then isolation. So that means a lot more tests. And how many tests will we need to be able to achieve that level of surveillance?
And I think that's a great question because, if you have too much tests, you're not going to have access to, it's all about accessibility. I think that's one of the big aspects to understand. I know that, the number of 25,000 and more has been thrown around. That's a very good number to get going. And as we continue to expand testing capabilities across the state, University of California included, the 5 hospitals, this will provide the capacity. The other part of this issue is that we need to get people going to places that have access to this capacity, right? Accessibility is a big topic, and the task force in part has been trying to overcome these accessibility issues, in part partnering with certain industry to be able to deploy these smaller bedside rapid molecular tests for COVID-19 that could get results in about 5 to 13 minutes. Last I checked, these devices were spread across 13 healthcare delivery systems in 75 different sites. And as noted, working with the University of California, because we're so strategically and geographically located throughout the state and have the capacity, we're now tasked to be able to go out there, and not necessarily when I say go out there, not people running out there, but we're calling people, we're receiving messages from entities that want to get access, where these hospitals previously either didn't have testing, they've run out of testing, or the laboratory they were sending tests to previously couldn't give results in a reasonable amount of time. They're coming to us because we have the capacity and we get results out relatively quickly.
Now, as we, in some ways, maybe decentralize some of the testing, right? So we talked about the larger labs, commercial labs, hospital labs, and so forth. But if we're starting to do more point-of-care testing, what is the reporting infrastructure like? So now, say we are doing more testing, and you go to your doctor's office and they're doing the, test result right there on the spot. How is that information getting to, public health? Do we have the reporting infrastructure in place so that we can actually track all of this?
Yeah, sure. And that infrastructure has been in place for quite a while, actually, believe it or not, as a state, and there's a system called CalReady. And so a lot of these reportable diseases, we were reporting with syphilis and all these other things, influenza in the past, too. And so these are being reported in, and as well as COVID-19. And so this data is funneling in to track, to be able to see how we are doing across the state as a whole, and to see where in each county, city, how they are doing relative to the population, right? So we want to be able to get people where they need testing to then target to these places that make sense, right? You don't want to have someone from Sacramento have to send their sample all the way to Los Angeles. That doesn't make sense, especially when we have UC Davis here with good capacity, as well as other places within the Northern California.
So how many tests can California run today?
I think that number is very dynamic, so it keeps changing. But, last I checked, even amongst our UC sisters, we could probably bring it all the way up to about close to 10,000 tests amongst the 5 UC hospitals. I just want to point that out. I know, at Davis, we could go over 1,000 tests. I know the UCSF has their own hospital lab, so they have this Tran Zuckerberg BioHub, which has scaled up significantly, and, much kudos and credit to them. I've seen the news they're starting to offer free testing, which is amazing. And as our San Diego sister institution can, last I checked, 1,000, maybe even 2,000 tests down there. So as you look at it, we have 5 UC hospitals that could do between 1,000 and 2,000 tests per day. We can easily get up to 10,000 alone there. But that obviously means that there are other hospitals or labs out there that are doing tests too. So clearly the number will be much greater than 10,000 tests a day. So we're quite proud of that. And the number continues to grow.
And now you've mentioned some of the shortages along the way, reagents, swabs, viral media. So what are the bottlenecks? So we refer to some of them to testing. And what can we do to open up these bottlenecks so we can actually get the level of testing we need to do to eventually lift our stay-at-home orders?
Oh, that's a great question. So those numbers I gave you, I mean, I know we're doing those large numbers of tests across the state, but yeah, we're tempered a little bit with these other ancillary supplies. So reagents, I think at UC and Davis included, supplies are looking good for the test itself. But the swabs and media are the ones that are starting to slow us down because, every swab, every media requires, is needed for every test. So the state task force has been looking at different supply chains, getting swabs in. I know there are different institutions, including UC Davis, Stanford, San Diego. We're looking at even 3D printed swabs of all things, right? And these folks can Google it up. They exist, and we have to do it in the right way. They are a certain level of classification by the FDA, so we have to follow through some steps with that, and we have to make sure they're sterilized. So, at Davis, for example, we've been studying for a while to see what's the best way to sterilize these 3D printed swabs so that they are safe for people, but it doesn't compromise the swab itself. If you were to heat up the swab to a hot temperature, it could make it brittle, for example, or melt. Those are things that we have to think about. And so we're looking at all these innovative ways across the state and at these academic places to resolve this issue. At Davis, we're also looking at producing our own media. And so we're trying to bring a lot of these things in-house where we can to help ourselves, but also relieve the burden for the rest of the community and state. If we don't have to access more swabs and supplies or a lot of it, we're helping others. And we're helping ourselves, too, because we're still able to offer the testing we need.
Now, California is a big state. Is this something that should be done by, let's say you mentioned UC Davis is developing, trying to manufacture own media and so forth. Should we try doing it at a larger scale? Is there something the state should be doing in terms of saying that, okay, I have a shortage of swabs and media. How do I manufacture this more in mass? I don't know whether 3D printing is the fastest way to do that or not. Should we be doing more in that regard?
Sure, yeah, no, and that's actually being looked at. And I think those are really exciting things, and it actually speaks to how amazing the state is because we have these resources, So there are in-state 3D printing companies that can print thousands upon thousands of these, possibly even tens of thousands of these on a fast pace. So those are being looked at as options. We want to make sure that we're picking the right ones. We want swabs that work, right? 3D printed swabs that work. That's why we have academic institutions looking at this to help the task force. And with all those swabs, you can have 1 million swabs come up, but then you need to sterilize them. So where can we sterilize 1 million swabs at once? Those are questions that are being asked. But again, like I said, there's amazing resources in the state that allow us to do this and through public-private partnerships.
So I think a lot of people will be asking, how long will it be before we can do enough testing? So I asked about how many tests we need to do, and we talked about bottlenecks, but how long will it be before we can do enough testing so that we can finally have some conversations about lifting the stay-at-home order? So I know it's only one of the 6 items that the governor pointed out, and testing is only part of that number one part, but it's a very critical part. So do you have an idea? Are we talking months, weeks, hopefully not year?
Definitely not years. That's certainly not on anyone's timelines to be years. I would say that things are moving fast. They're very dynamic, and we're going in the right direction. So with serology testing starting, we heard a week and a half ago, if I recall, that Stanford has started testing. I know other places have started testing at UC Davis and our sister UCs. In the coming days, you'll hear from us too, if not already. And so these big places where these instruments can be doing 1,000 tests, 2,000 tests a day. So these serology tests are going to provide us with a lot of situational awareness in the state as we grow forward. And I think it's too early to say how fast because I want to emphasize that as we gain more knowledge of how prevalent this disease is, it actually will shift what the timelines mean, right? Because we find out if this disease is not permeating everywhere and anywhere, that changes how we would respond to it versus knowing that there's 30%, 50% of the population that already had been exposed. And we also have to temper that a little bit because we have to be sure that the tests we're doing are appropriately accurate and precise to give us the right information to act on. And that's why we have to see as both Stanford, UC, and other institutions start widespread testing, that information will help inform our next actions.
So when we talk about doing more testing, I think we previously touched on different types of tests. So when we finally try to get to that place where we're doing identification through testing, is it testing people with the PCR? Is it testing people with serology? Is it doing both? So someone comes in and say, okay, you know what? We've identified someone who's positive for COVID-19. You're a contact. You may be an asymptomatic carrier. We don't know. So you need to report to or call your doctor, report somewhere, and we're going to test you. And so what would you imagine that we would be doing? Both a PCR and a serology test on that person, one or the other? What do you think it's going?
Yeah, that's a good question. So it'll be depending on the scenario.
Mm-hmm.
So if we're going to do community-wide screening, I'm going to test everyone in Sacramento County as an example. We would probably stick with serology, especially someone who's coming in with no symptoms. Right? They feel well. They haven't had any issues, and we'll do serology on them. But if we want to look at asymptomatic employees, these are employees that could be in the actual front lines and so forth. We might want to look at PCR and serology, right? The reason for that is we don't want to miss on a situation where we're in between someone who just got infected and they haven't produced the antibodies yet. At the same time, we don't want to be in a situation where they are infected but asymptomatic, and we know that this is an issue with this virus. You could have the virus, an actively shedding virus, but you're not sick or may not feel super sick. So that's why, and at that point, at the early phases, you may not have the antibodies, but you may be PCR positive. So that's why there's value for that, especially amongst the healthcare worker screening. But in terms of the community, especially someone who feels well, the serology test by itself is a good start. And again, it's important that we do that. In fact, it might be even a little bit more important in my scientific perspective because of the fact that as we test more of the community with serology, we know the prevalence, and that determines how well we know these tests are reliable enough to predict the widespreadness of this disease.
And in terms of, I think one of the questions out there, and I don't know if you've run into an answer to this one yet, is that someone gets infected with COVID-19, they recover. How long are they still infectious for? Is someone, when they're recovered, also not infectious? And is that something that's detectable by PCR since it detects viral load?
So I think for the most part, for the vast majority of patients, our understanding is as you get discharged, you feel better, and you've had negative PCR results, possibly even 2 consecutive negative PCR results, you're less likely to be infective. And I say less likely because even today on the news, there's a set of cases, about I think 144 from Korea, that showed that some of these individuals that have been discharged, they're fine, they were negative. And they got retested again a certain amount of time later. They got positive on PCR again, and that may scare people. But people need to kind of calm down for 1 second because we have to look at science. The PCR test looks at the genetic makeup of the virus, not the live virus that necessarily causes disease. So it's possible that this is just more viral genetic shedding. These are the viruses that have just hung around a little bit longer. They're not going to cause infection, but just falling apart, releasing their genetic material, or maybe something else that we don't know biologically. Or conversely, these are shedding viruses. And this is why I think the article this morning, they actually said it's going to take another week or two to determine what they're shedding is actually live viruses. And it implies that these groups, these patients, these samples are getting viral culture to grow the virus. If the virus grows, then yes, that is something that can cause infection. So I think for at least these 144 individuals, the jury's still out. So I would say that the vast majority of folks that have been discharged, have had an infection, they're very unlikely to infect others, especially based on what we know about virology. But this virus has a couple tricks up its sleeve, as it seems.
Well, certainly I think that shows the importance of understanding what the test actually is measuring. So somebody's thinking it's a COVID-19 test, but what is it actually measuring, and what does that mean? So does that mean that person actually is infectious versus is it just that they're shedding RNA because the virus is dying, being actually taken care of in the body? So that's, I think, is a very important caveat to remind people about test results.
Absolutely.
And then finally, I guess, what are the questions about COVID-19 that still need to be answered before we can implement an effective testing, contact tracing, and isolation strategy? So I think just talked about one of them, right? Is someone potentially infected after they recover? I think there's also some issues around, for example, the serology, whether what you're picking up is blocking antibodies or that will actually lead to immunity. But are there sort of outstanding questions about the way the virus works that will affect the way we interpret these results?
Yeah, I think so, because I think the 1,000-pound gorilla or whatever animal in the room is what do the asymptomatic people look like? The ones that have been moving around in lives, and I heard some stories or actually articles already that the virus has been already lurking around since November. So what's the viral shedding and viral load looks like? Why are there situations where when we test with some of the best technologies we have, we get a negative result, and it's not the test? We've looked at this, and it's in part due to the virus shedding in different spaces of the body in different concentrations over time. And just to emphasize, if you put a swab up someone's nose and there's no virus there, or the virus wasn't captured on the swab, you got the perfect test in the universe, you're not going to pick it up. So these are the questions there. What happens when a person gets super sick? Well, what dictates a person who doesn't get sick versus others that do? We've seen some correlations with different comorbidities, such as obesity. We've seen that. But again, what makes a difference? Why are children having less severe cases than adults, and especially and conversely the elderly? So lots of questions with this one, and this helps us from a campus standpoint, Davis, where we're studying this in various different models to help better understand this. And of course, last and certainly not least, what about the immunity topic? Does having blocking antibodies actually confer lifelong immunity, or is it just transient? Dr. Fauci, I think, brought this up a couple days ago that we still don't know yet. And if we get infected again next year, even though we were exposed prior, do we still have disease? So these are a lot of questions that we still have to know, and we're doing it, as they say, we're trying to fly a plane while building the wings, and this is what the nation's dealing with right now.
Well, that's certainly very helpful. I want to also, because you mentioned about when did the virus show up, I understand that some studies being done at Stanford, they were looking at blood samples and looking at antibodies, had traced the virus probably first showing up in maybe early February or late January. Have you heard other information?
Nothing yet, and that's where a lot of these reference labs, big academic centers are going to play a big role, because we have biobanks of samples that should be tested with good serology tests. And so I think this will become more widespread as better serology tests become available. You don't want to test with a bad serology test, right? And at Davis, we have an accredited biobank where individuals have graciously consented to allowing us to store their samples in a de-identified way. We don't know who the patients are, but it allows us to store for the sake of bringing up new tests, and so forth. And again, these are people that these are patients and volunteers that have said that I am willing to provide these samples because for the greater cause, right? And so we have these samples. Same with reference labs. They've been running hundreds of thousands of samples monthly or daily, and they have these. And so as they test back far enough, it'll be interesting to see how far it goes.
All right. Well, thank you very much, Dr. Tran. Really appreciate it.
No, thank you.
So thank you for listening to this episode of Putting the Public into Health by Dr. Richard Pan. If you have questions or ideas for a future podcast, please email them to senator.pan@senate.ca.gov. Please stay at home as much as possible, stay at least 6 feet away from others outside, wash your hands frequently, and try not to touch your face. Together, we are slowing the spread of the disease and saving lives. Thank you so much for listening.